Welcome to Coding for Health-Related Social Needs and Social Determinants of Health. Our speaker today is Rachael Willeford. Rachael is the Senior Coverage and Reimbursement Specialist in ASCO's Care Delivery Department and is a certified hematology oncology coder with over a decade of oncology revenue experience in multiple practice settings. She acts as a main point of contact for billing and coding inquiries, in addition to producing oncology-focused educational resources for provider and practice support. Rachael also serves as staff liaison to ASCO's American Medical Association activities involving the CPT editorial panel and the RVS Update Committee. Outside of her ASCO role, Rachael volunteers her time as an officer for a local chapter affiliate of the AAPC, a national organization for the business of healthcare. Thank you, Rachael.
Thank you so much. I'm really happy to be here today. This has been a really popular topic. And so we're going to talk today about coding for health-related social needs and those social determinants of health that are connected. Just one note prior to our discussion today, you may see some small numbers on the slides within the presentation. Just know that those numbers correspond to references that are available at the end of the presentation should you want to look at more resources. So today, the topics that we're going to cover is identifying the services that address these health-related social needs, knowing what they actually are, and then recognizing the reporting requirements for the patient navigation codes, and finally, connecting the social determinants of health conditions with ICD-10-CM codes. First, though, let's go over what social determinants of health and health-related social needs are. These seem to be very popular, but what are they actually? Social determinants of health are non-medical conditions related to an individual's living, learning, and working environments that affect one's health and associated outcomes. These are things like social, economic, and environmental conditions that are faced by individuals and communities. Health-related social needs are associated and connected to social determinants of health because they are those needs that are affected by social determinants of health. There are those experiences and unmet needs that affect one's health and well-being, which arise out of adverse social determinants of health. So back in 2022, there was a report from the Office of Health Policy. And in that report, it estimated that clinical care impacted only 20% of county level variation in health outcomes. Meanwhile, social determinants of health may potentially affect as much as 50% of health outcomes. Factors like poverty, employment, and education having the largest impact on those outcomes. So how can these barriers be addressed? Well, social services addressing health-related social needs are the way to address these barriers. However, historically, these services haven't been reimbursed even if they've been provided. That's why in the 2024 final rule, CMS created a new code set to support activities that encourage addressing and managing social determinants of health. The result came out of this is 3 separate identified services: community health integration, principal illness navigation, and a social determinants of health risk assessment. The first of these services is community health integration, which is initiated at an E&M visit at which a problem is addressed and for which social determinants of health are identified that significantly limit the provider's ability to treat and diagnose the problem. Certified and/or trained auxiliary personnel, which may include community health workers, then perform supportive activities that make up the community health integration services, performed under general supervision of the initiating provider to address the social determinants of health-related needs. The next service, principal illness navigation, is similar to that of community health integration, but these services focus on a serious high-risk illness rather than social determinants of health solely. So what exactly is a serious high-risk illness? Well, CMS defines this being as a condition a serious high-risk condition expected to last at least 3 months and places the patient at significant risk of hospitalization or facility placement, acute exacerbation or decompensation, functional decline, or even death. This condition requires the development, monitoring, or revision of a disease-specific care plan and may require frequent adjustment in the medication or treatment regimen or substantial assistance from a caregiver. Principal illness navigation services may be performed by auxiliary personnel who must be certified or trained on the serious high-risk illness or condition that's addressed in the initiating visit, in addition to the navigation. These personnel can include staff like cancer navigators, mental health navigators, social workers. Also, certified peer specialists may provide services that focus on the behavioral health conditions. So community health integration and principal illness navigation include some of the same activities. Personnel activities may include communicating with all the service providers regarding the patient's psychosocial requirements, their preferences, and desired outcomes. Education may involve building self-advocacy skills and educating the patient on how to best participate in medical decision-making. In principal illness navigation, that education component may also include providing the patient with information for participating in clinical trials. Coordination may look like coordinating services and care transitions between all community and health-based providers and practitioners. These services may also involve facilitating access to community-based social services as well as healthcare access. The actual navigation component may include providing social and emotional support to cope with the problems addressed, the social determinants of health needs, and daily routines in order to meet treatment goals. CMS has also said, including, in addition to the support, the staff may also provide mentorship and inspiration based on their lived experiences. And finally, the establishment of an action plan through a person-centered assessment may also be included in these activities. One way that the two services do differentiate is the role of facilitating access. So community health integration facilitates access to care and community services, while CMS has stated that principal illness navigation may also refer the patient to applicable healthcare and community services. Note that this does depend on scope of practice for the personnel. The third service that has been created is social determinants of health risk assessment. This is used to report the administration of a standardized evidence-based social determinants of health assessment tool. At a minimum, the tool used must must assess the patient for at least 4 specific categories: food insecurity, housing insecurity, transportation needs, and utility difficulties. The tool may also include other items that could potentially affect compliance and the social needs of the patient, but at a minimum, documentation must demonstrate that there was an assessment for at least these 4 items to be able to report the code. Now, CMS has been clear on this service. The intent for the code is not to screen all individuals. Rather, it's meant to assess a patient with suspected or known social determinants of health needs. We mentioned that the social determinants of health risk assessment uses an evidence-based tool. Now, we've listed a couple of examples here. However, this is not an all-inclusive list. We provided 3 examples of these tools. Oncology folks may be familiar with the NCCN distress thermometer and the tool that's associated with it. CMS has also given the AHC health-related social needs screening tool and the Prepare tool as examples of these evidence-based tools. So as a quick summary in this section, practices can utilize services that address health-related social needs to mitigate social determinants of health through community health integration. Practices can help navigate patients through serious health conditions with principal illness navigation, and assess patients and evaluate social determinants of health with evidence-based tools. Now that we know what the services are and what they entail, how do we report them for reimbursement? While the physician or qualified healthcare professional may choose to furnish the navigational services themselves, typically these services are performed by auxiliary personnel under the supervision of a billing physician or practitioner who performs the initiating visit. Who are these auxiliary personnel? Auxiliary personnel are individuals who work under the supervision of a physician or qualified healthcare professional. These individuals may be community health workers, nurses, nurse managers, clinical nurse specialists, social workers, navigators, patient navigators, or peer support specialists. This is not an all-inclusive list, but simply demonstrates examples of what staff may look like who perform navigational services. Now, CMS does outline what they think that certification and training should include, what they have requirements for. However, they are going to defer to state law and applicable scope of service for specific categories of workers. So if there's a state law on file, they're going to defer to that. However, in lieu of or in absence of some state law, they specify that certification and training must include patient and family communication, relationship building, navigation and advocacy, professionalism and ethical conduct. And in addition, for the principal illness navigation services, not only are those personnel supposed to be certified and trained on navigation, but also on the serious high-risk condition that the patient is being navigated through. For the patient navigation codes, the community health integration and principal illness navigation, these services, again, are performed typically by auxiliary personnel under general supervision of the provider. It's the practitioner who performed the initiating visit and identified the needs for that community health integration or principal illness navigation would be the billing provider and report the actual codes. It's important to know, though, that there needs to be some type of employment relationship between the practice and the performing auxiliary personnel to report the navigational services provided. Auxiliary personnel staff must represent some type of financial expense to the practice, either by direct employment, contractual or leased agreement, in order to meet those incidental to requirements. All services must be reported by a billing provider who performed the initiating visit and can bill for the services independently. Now, during the navigational period, it's expected that the provider remain actively involved in the care of the patient. So it's not just that this person is being referred for these services and not involved in the period itself. So these codes were based on the framework was laid by the chronic and complex chronic care management and care management codes. So there's kind of similar restrictions for these codes. Community health integration is very similar to that of chronic care management, in which only one clinician per beneficiary per calendar month is allowed. Principal illness navigation, very similar to that of principal care management. More than one clinician per beneficiary can report these services. However, they have to involve different conditions for the navigation. There are also documentation requirements in order to report these services. In addition to the specified training, CMS provided guidance on the specific documentation needed to report these codes. Community health integration services require an initiating visit, typically, but it's not limited to an E&M visit. At this visit, the physician or qualified healthcare professional must identify social determinants of health needs that limit the ability to treat that problem and establish a treatment plan at the time of the visit. At this visit, the provider must identify social determinants of health needs that limit that ability or to treat or diagnose those problems. And the patient record should reflect those social determinants of health needs that have been identified, and then any additional needs that are addressed during the navigation continuum. Principal illness navigation, I think you'll see, is very much like community health integration. It's just a different focus. Principal illness navigation focuses on that serious high-risk illness rather than solely the social determinants of health. So these services require an initiating visit that identify the medical necessity for navigational services needs being identified at that initiating visit. So what exactly about this patient's condition requires these services? The patient record should also reflect the social determinants of health needs that are identified, if there are any, and any additional needs. The time component for both of these services. So for community health integration, that time is spent furnishing the activities which address the social determinants of health. That should be documented along with a description of the activities. Meanwhile, time for principal illness navigation is spent rather furnishing the navigational services for that condition. That's going to need to be documented along with the actual services themselves, like what happened, what of the activities that make up these services were performed, how were they performed, and what methods were used. Both the community health integration and principal illness navigation require advanced informed consent, which we'll talk about in the next slide. Now, that last category, the social determinants of health risk assessment, you can see this, it requires a lot less documentation. However, there is some documentation required. First, the assessment must use an evidence-based tool to evaluate social determinants of health, like we talked about. It may be performed on or before an associated visit, such as an E&M, annual wellness visit, or even transitional care management. Lastly, identified social determinants of health may be documented with the Z codes. Now, that initiating visit, which ones can they be? Well, it cannot be a low-level service, so not that 99221. It can be other services as outlined in here and as outlined in the resources, but not that low-level visit. I wanted to specify that. I mentioned advanced informed consent on the last slide. So either written or verbal is required, but it's required to be documented in the patient's medical record before providing the services. The patient should be aware of applicable cost sharing, restrictions such as only one provider that can bill these community health integration services, the ability of the patient to discontinue these services at any time. Consent must be done at least once for the community health integration. If the patient changes to a different provider, it would need to be done again, but only once for the community health integration. It is expected to be done annually for principal illness navigation. We know what's required to report these codes, but what are we going to get if we do report the codes? So CMS did allude to the fact in the 2024 physician fee schedule final rule and confirmed in the health-related social needs frequently asked questions document that was released in the spring that reimbursement is established for both the office and facility settings. So let's look at what that's going to look like. We're going to talk about the office setting first. Reimbursement in this section is based on information for the national rates for the non-facility setting provided by CMS in the Medicare physician fee schedule. Actual rates are going to vary based on your reporting location. So CMS used the chronic care management codes as a basis and framework for reimbursement for these services. The G0019 would be reported for the first 60 minutes per calendar month for the services, and each additional 30 minutes per month reported with the G0022. Reimbursement in 2024 is currently set at $80.56 for the primary code and $50.26 for that add-on code. Now, in 2025, we're looking at reimbursement being $77.96 and $48.52, respectively, with the cost sharing estimated at the CMS 20%. Currently, rural health centers and federally qualified health centers would report these services along with principal illness navigation with the G0511. However, in 2025, that's changing, and CMS is going to require the individual HCPCS codes to report these services. Since principal illness navigation and community health integration are based on the same framework, the same RVU values, the codes are reimbursed at the same amounts. 2024, again, $80.56 and $50.26 for the national non-facility rate. In 2025, we have the same reimbursement as that community health integration at $77.96 and $48.52. To be noted, the add-on codes for both the CHI and the PIN currently have no frequency limits imposed on them at the moment. There's nothing in the final rule establishing any. Next is the Social Determinants of Health Risk Assessment report. You would report these with G0136. That would account for an assessment taking 5 to 15 minutes, not to be reported more than once every 6 months per provider. Reimbursement is currently set at $18.97 for 2024. For 2025, that's going to be $18.44 with your cost share estimated as shown. Next, we're going to talk about the facility setting. So in the facility setting, reimbursement is made to both the provider according to the facility rate that's established in the physician fee schedule, and then reimbursement may also be made to the facility according to the rate set in the OPS final rule files. Reimbursement included in this section is based on the rates provided by CMS in Addendum B for the OPS final rule for the facility, and then the national rate for the facility setting according to the physician fee schedule. The community health integration and principal illness navigation services are included in APC 5822. That's for level 2 health and behavioral services. The add-on codes for these services have a payment status indicator of N, excuse me, which means that the payment's bundled. For 2025, the facility would be reimbursed for that primary code of G0019 for $92.50, and the physician would be reimbursed for both the primary and the add-on code, so $47.55 and then $33.32. And then we have the cost sharing that's estimated based on the 20% from CMS. Again, it's same setup, so it's the same reimbursement rates and the same bundling. You're going to see the physician and then the facility, and then the cost sharing would be about $18.50 for the facility and $9.51 for the physician for that primary code. There would not be a add-on code in the facility, but that physician's the physician rate cost share would be $6.66 for those codes. Finally, you have the Social Determinant of Health Risk Assessment. This is included in a separate APC. It's 5821 for Level 1 Health and Behavioral Services. Facility would be reimbursed at $29.79 in 2025, and the physician at $8.73. Your cost share would be $5.96 for facility and $1.74 per physician. So we have an example. We wanted to kind of give an idea of what it may look like. Of course, your workflow is going to be unique to your practice. So in our example, our patient has breast cancer, is receiving chemotherapy every 2 weeks. At the visit, the physician brings up potential clinical trials that the patient may qualify for, and the patient's expressing concern about the treatment frequency because it turns out the patient's sharing the family vehicle with the spouse, so it's making getting to appointments really difficult for them. Because of medical bills that are related to the diagnosis, the patient's seeing a lot of financial strain, and the stress with all of this is affecting the marriage. So at that E&M visit that the patient is seeing the physician for clinical staff, the physician decides to get clinical staff involved to conduct a social determinant of health risk assessment under the supervision of the physician. And then navigation is engaged to address those concerns that are uncovered at the visit. So potential navigation to identify help with transportation and connecting that patient and the spouse to the support system, potentially even like financial navigation to help them with financial assistance, but also clinical trial information about clinical trial participation. That's an education component. Note that the physician is not going to be involved. The physician's going to monitor the progress and see how this is going as well as they follow up. So what's that going to look like? So the physician would report the applicable E&M code for the office visit. And then because his staff did this as auxiliary personnel as incident 2, would report the G0136 for that risk assessment. The navigation team would be performing the services during that calendar month, but the physician is going to be, the initiating provider is going to be reporting the actual G0023 and any G0024 once that time is reached for these services. Now that we know about the navigation services, along with reporting those services for the navigation code set, it's also important to utilize the ICD-10-CM code set to indicate those conditions that are affecting the patient. So what exactly are ICD-10-CM codes? Because I know that a lot of times the coding language can be a different language altogether. ICD-10-CM stands for International Classification of Diseases, the 10th revision, clinical modification. The ICD-10-CM code set classifies diagnoses which indicate the reason for a visit or encounter in all healthcare settings, both inpatient and outpatient. It's important to remember that this is a statistical code set. Data that's included can be used to impact practice decisions, but data can also be used to influence policy decisions on a much broader level. So how are these codes connected to social determinants of health? So there is a section in the ICD-10-CM code set, the Z codes that are Z55 through Z65. Those may be used to identify patients with potential health hazards related to socioeconomic and psychosocial circumstances. These directly correspond to social determinants of health. Using 2019 data, Medicare conducted a study regarding Z-code utilization among Medicare fee-for-service beneficiaries. This study found that among 33.1 million total Medicare fee-for-service beneficiaries, approximately only 1.59% had claims that had Z-codes on them. Other studies that showed percentages for Medicare Advantage plans, those rates were even lower. Now, one reason for the lack of utilization is a lack of awareness regarding these codes, which is why we are here today to address. By reporting the Z codes and identifying patients with social determinants of health, this hopefully will lead to an improved quality of care, improved care coordination, as well as an improved experience of care. If a patient's identified as having social determinants of health, now then what? Well, we need to connect those social determinants of health to a Z code. There are 10 categories of Z codes currently related to social determinants of health, which may relate to things like health literacy, transportation, housing insecurities, food insecurities, and more. It's important for a practice to connect social determinants of health with the appropriate Z codes, and CMS has broken it down into a 5-step process. First, the practice collects the data itself. This can be done with things like health risk assessments, screening tools, person-provider interaction, and patient self-reporting. Those questionnaires that we fill out before our doctor's visits and provider visits. That's collecting social determinants of health and data. Next would be documenting that data in the patient's health record. Then the data would be mapped to Z codes. You would select the appropriate ICD-10 Z code that corresponds to the social determinants of health. And we're going to talk about that and reporting in the next couple of slides. The data should be analyzed and added to reports. Now, these may be internal reports, but they can also be shared with social service organizations, providers, and health plans. And this data would also be beneficial to identifying unmet patient needs. What social determinants of health are the biggest issue and therefore a priority? This can be relevant to a practice, a payer population, or even showing trends that can be utilized to update and create new health policies. So let's think back to our patient in the principal illness navigation example. In the discussion with the patient, that patient's telling the physician that they were having financial issues, difficulties with transportation, and marital problems. In our example, they're talking about significant stress that they're having. So what are we going to do about that? Well, since the patient has practical concerns involving their expenses and financial issues, their transportation and relationships, these can be linked to actual Z codes that are in the that are diagnosis codes. You can find problems with money and finances, transportation insecurity, marital problems. Those are located with the ICD-10-CM index. Now, these codes would then be confirmed in the tabular index of the code set to ensure that you are correctly coding these conditions. In 2025, some of these categories may even be more granular as there are additional Z codes being added to the code set. Now, there is a caveat here. There's not always a one-to-one match. Some codes can be a little bit ambiguous, and there may not even be a specified code in existence, requiring the use of an unspecified code. To illustrate that point, I'm highlighting section Z59 here, problems related to housing and economic circumstances. This section demonstrates not only a lack of, but a multiplicity of codes, where we have very specific codes and then kind of more ambiguous codes. As you can see here, there are a number of codes that address housing and specific issues with housing. But also on here, you only see one code for transportation insecurity. So while you can get really specific as to how housing is affecting a patient, when we see a patient who's being affected by transportation, that's all we can say. So some wrap up on the ICD-10 codes and takeaways from that. First and foremost, always code to the highest level of specificity that is supported by the documentation. Secondly, ICD-10 guidelines allow documentation from other clinicians that are involved in care, but not necessarily the patient's reporting provider to be used when coding for social determinants of health. That's specific to social determinants of health. And then finally, you should include all other relevant diagnoses in the claim and medical record as they are appropriate. For example, that serious high-risk condition like the patient's cancer that you are assessing and treating, and that is the reason for this service. So key takeaways from this presentation. First, services that address health-related social needs were created to address increase patient access to navigation and care. Patient navigational services may be reimbursed with the newly created G codes for services that address health-related social needs now. Historically, these may have been not reimbursed in the past. Social determinants of health needs may be indicated in, in the claim by linking ICD-10-CM Z codes to perform services. We'll go over a few resources for you. There are references here that were used in the creation of the presentation. I've included them in case you wanted to refer back to those resources. We have about 11 of them that were used. Also, ASCO also has resources that are available, the first being a care management and patient navigation services comparison, along with a resource for coding and reporting social determinants of health. ASCO also has a policy statement that's available for social determinants of health and cancer care. In addition to these three, there are a number of educational books or articles that ASCO has put out regarding the social determinants of health needs and health equity. Among the resources ASCO has made available, you can find these resources on the coding and reimbursement page. You can find ASCO's tip of the month. You can see timely updates for not only your CPT codes, your HCPCS codes, and your ICD-10 updates, but there are also guides for evaluation and management and practice administration guides for topics such as advanced care planning, care management, and then that coding and reporting for social determinants of health. To find these and other resources, head on over to asco.org. To find these, you're going to select their coding and reimbursement section under the Billing, Coding, and Reporting tab. See, I want to make sure that everyone is aware that CMS also has resources available for this. I mean, they did create the social services that address health-related social needs. So they have resources on that as well as care management, and you can find additional information in their final rule. We also have included information on the health-based assessment tools. While there are links to this, you can also search these on the web. Finally, if there are any questions, they can be posed to ASCO staff.